gestational trophoblastic disease, under whom it is called gestational trophoblastic neoplasia. So neoplasia means it is likely to be malignant. Neoplasia may be benign, may be malignant, but when we are dividing these diseases, this includes, we do not know benign or malignant, but this is definitely malignant. These are the diseases not from the mature human cells. These are the diseases of the trophoblastic cells. You know, trophoblast itself is very immature. It has a very invasive character. It penetrates the decidua and causes placenta, formation of placenta. So practically, it is a disease of the placenta. Placenta means it is chorion, not the amnion. Amnion is going to form the baby, but embryo. But it is the disease of the chorion. That means it is trophoblast. When lined by mesoderm, it is called chorion. That is primary mesoderm. So diseases of the chorion. So we will come to what are the diseases which are included. But most common form which you find as a specimen in our departmental library, it is Hydatidiform Mole, or it is a molar pregnancy. This is molar pregnancy. Moles means mass. So this is not, this is pregnancy because it comes from the zygote after the gamete are united. So this is pregnancy, but there is no fetus. Only placental tissue transformed into a vesicle-like structure that is called molar. Molar means mass. So vesicular structure, it is transformed macroscopically. That's why it is called a molar pregnancy. So this is, what is this? Molar pregnancy is not a degeneration, not inflammation. It is a proliferation. So proliferation means neoplasia. So which are the structures which proliferate? It is the trophoblast. So consists of two layers, syncytium and cyto. So both the layer proliferates. So under microscope you will find tremendous proliferation of syncytium and cytotrophoblast. And so diseases of the placenta, incidence is 1 in 400 in India. It is much. In European country it is 1 in 2000 or like that. But in Asian countries it is much. And more in Asian population, it is a benign disease. Benign disease because it does not penetrate it does not invade the myometrium. So decidua arrest the growth. That is, it is benign. If it penetrates the decidua and reaches the myometrium, it will not remain benign. It will be malignant. So benign disease with malignant potential, it has the potency to grow more. So any time we do not know, it will be converted to malignancy. So always we have to remain alert when the patient is going to a malignant situation. So that is very important. So macroscopy is like this. So this is molar mass, vesicle-like structure. This is the blood, the complete mole. This specimen you will find in our departmental museum. So you will describe that specimen. vesicles of varying sizes, arranged in clusters, not single, clusters, bunches. Areas of hemorrhage which we have shown, fetal elements not there. If you find any fetal elements like skull, like body, like limbs, then it will not be a complete mole, it will be a partial mole. So, partial mole you get some fetal elements, but in complete mole you do not find any fetal elements. So, which one is more proliferative? To complete mole. So, partial mole, because some fetal elements are there mature, so it will not turn into malignancy easily. So, because the trophoblast secretes what? HCG. HCG stimulates ovary form the luteal cyst, theca lutein cyst. So, LH-like activity, theca lutein cyst. So, theca lutein cyst, both the ovaries will be there, not the single ovary from which the ovulation is going on, because it is in general stimulating the ovaries. So, theca lutein cyst in both ovaries. High HCG release from the trophoblast. So, these are causing, because of the proliferation, this will cause this cyst. So, macroscopically it is the uterus and ovaries, the features will be like this. So, more enlarged picture, these are the vesicles and these are the hemorrhages, and this is forming the clusters. So, whenever you get when it is taken out from the uterus, this is a conglomeration of vesicles. So, this is a picture will be like this. So, if you are shown a picture and if you are asked to diagnose the condition, you have to write it is a molar pregnancy or vesicular moles. Microscopically. So long what we are telling, a trophoblastic proliferation, so both the layers in situ will be tremendous proliferation, multi-layered. Edematostroma, you see, the placenta consists of number of villi, primary, secondary, tertiary villi. But here is the situation, vascular degeneration. So, villi contains what? At the core is a vessel, then it is stroma, then it is both the layers of your trophoblast. But here, vascular or vessels are not there. So, you are finding so many hemorrhage. From where these hemorrhage are coming? It is from the decidua, not from the molar tissue. Molar tissue is avascular. It does not contain any vessels in the villi. Villi is there. Villi structure is maintained, but no blood vessels. It is converted into vesicle because of the accumulation of fluid within the villi. So, vascular degeneration, absence of blood vessels, so on microscopy, and villus structure present. Why the villus structure is present? Because it is not that much neoplastic, that not much proliferation becomes to be malignant. If the malignancy develops, then villus structures will be lost. So, that will not be molar pregnancy, that will be some carcinomatous situation. So, villus structure is present and cellular atypia not found because it is a benign condition but malignant potential. So, cellular atypia not found. These are the features on microscopy on which you will say whether it is a mole or not mole. It may be some malignant situation. That is microscopy. You see, this is the villus core. So, around which this is proliferation of the syncytio and cytotrophoblast proliferation. And this core of the villus is edematous, accumulation of fluid. So, here is the proliferation and the accumulation of fluid. So, there is no vessel here, that is on microscopy. You know how it happens? That means pathogenesis. It is the problem with the fertilization. Usually, sperm and ovum should get 46 XY or XX. But here, fertilization by 23X, then this 23X gets doubled into 46XX. Not that other half 23X or Y, X from the ovum is not coming, because those are inactivated by some mechanism. So, genetic material was there, but that is inactivated. Because of that, this sperm gets duplicated. This sperm gets duplicated, giving rise to duplication of paternal chromosome, inactivation of maternal chromosome. That's why it is duplicated and giving rise to 46XX. And this process by embryology is called androgenesis, and that gives to complete mole. 46XX, 23X is duplicated and 23X from the maternal half is inactivated. So, that is androgenesis. It may be due to fertilization by two sperm from the paternal side. That can also happen. And that is fertilization by two sperm. So, maternal, no, that is another one. And if maternal chromosome is active, then it will be 69, 23X, 23X or 23Y, and there is another 23X from the X or Y from the, and that will be triploid. And that 69 triploid is equal to partial mole. So, if on immunohistochemical staining or like that, you do not find any maternal elements, that is complete mole. If you find the expression of maternal elements, it is partial mole. And in that case, chromosomal number will be 69. Both maternal and paternal chromosome is there. Staining with P57 is positive. That is maternal genes expressed in presence of paternal gene. That is P57 is positive. Amniotic sac, fetal parts present. Because it is 69, so amniotic sac fetal parts will be present because it is a partial mole. The chances of malignancy is less than 5%, very, very less, very, very less. That is very important. This is the pictorial presentation. So, maternal chromosome inactivation, 23X, and cell duplication. And this is in another dispermy, that means X and Y is coming, and this is 23XXY and giving rise to 69XXY. Triploid cells, maternal female, this is partial mole. Then how those patients will be coming to a gynecologist or our clinics. Bleeding, though it is avascular, but because it is proliferating, the surrounding structures becoming more vascular. Because of that, there is choriodecidual hemorrhage, so it will be presented as bleeding. Then amenorrhea, because it is a pregnant situation, so your 8 weeks or 6 weeks or 7 weeks of amenorrhea will be there, followed by bleeding. Pain abdomen, because the body is trying to expel this mass, the pain abdomen. And exaggerated morning sickness, because trophoblasts are more proliferated, so more HCG, so morning sickness will be more and more. In twin pregnancy, morning sickness also more because of two placenta. Here also trophoblastic tissue is only there, so morning sickness is more. And early onset preeclampsia means high blood pressure, proteinuria, that is called preeclampsia. That will usually occurs after 20 weeks in fetus with placenta in pregnancy. But here there is no fetus, no placenta, but the features, that is hypertension and proteinuria, will occur before 20 weeks. So whenever mother is coming and found that ill, very much high BP, so molar pregnancy is to be thought of. Sometimes with features of thyrotoxicosis. This is because of HCG has got thyrotropin-like function. It stimulates the thyroid gland. So, it is unusual presentation. Mother is coming with very much temperature, tachycardia, distress. So, features of thyrotoxicosis, and if on USG you find this molar pregnancy, that is from the thing, not the thyroid disorder, but because of molar pregnancy. Thyrotropin-like effect of HCG because of that. So, on examination, what will you get? Pallor, because of bleeding, blood loss, and pallor will be disproportionate because some of the blood are lost within the uterus. So, hidden blood loss. So, maybe external bleeding is less, but pallor may be marked. So, BP, as I have told, BP may be high because of preeclampsia onset. Uterus bigger than period of amenorrhea. So, because of proliferation, suppose 8 weeks amenorrhea, you are getting 12 weeks pregnancy. That means much proliferation. So 50% cases, not all. Dowy fills means there is no fetus, no amniotic sac. So, like this elastic fill, dowy fill, moidar moto. No fetal heart sound and fetal parts can be demonstrated by Doppler, by anything. And so these are the all signs. Expulsion of vesicular mass. So, along with the blood, if you find in your gloved hands there is vesicle-like structure in your hand, that is diagnostic that possibly she is suffering from molar pregnancy. So, what are the investigations? Obviously, we will go for a pregnant situation ultrasonography. So, that will give rise to snowstorm appearance, only proliferation, no fetus, no amniotic sac. And this is snowstorm appearance. This is echogenic mass with anechoic areas. So, these are the vesicles. no placenta, no fetus. Echogenic mass, anechoic areas, no fetus, no amnion. Excessive vascularity of uterus. On Doppler you will find uterus is very much vascular on Doppler, and mass is lacking of vascularity, but there is no vessels within the mass. Mass is avascular. In case of partial mole, amniotic sac and fetal parts are present. So, that is, along with that, if you get the fetal parts, then your diagnosis will be partial mole, not the complete mole. An invasive mole that we are talking, that if it proliferates and proliferates, not arrested by the decidual layer, then it will penetrate the myometrium. So, if on USG you find that molar tissue is penetrating the myometrium, your diagnosis will be invasive mole. Your diagnosis will be invasive mole. It is locally malignant, not malignant because it is not metastasizing to distant organs, but it is invading the local tissue, it is locally malignant. So, already we have described. So, other investigations, beta HCG. Obviously, in pregnancy, we just detect beta HCG. But if you go for the estimation of serum, how much it is 20,000 units, 30,000 units, usually around 50,000. In normal pregnancy, usually it may occur up to 70, 80,000, especially in twin. Rather than twin, more than 50,000 beta HCG is rare in normal pregnancy, but here it will be more. After 48 hours of evacuation, that will act as a baseline HCG. Suppose the molar pregnancy is there and you have to estimate the beta HCG after evacuation, and that will give rise to the baseline picture when molar tissue is expelled. Whether after that estimation, whether from serial estimation later on, whether it is increasing or not. That means whether all the molar tissue is cleared or some tissue is remaining there. That is serial estimation, 1 to 2 weekly monitoring of the disease. So, that is diagnostic purpose, usually beta HCG is not so important, but important is ultrasonography. But for monitoring, serial estimation of beta HCG is very important investigation. That is the investigation to know whether the disease is regressing or progressing. So, that is 48 hours after evacuation, after which if you go on 1 to 2 weekly interval, whether it is stationary, remaining stationary, or whether it is increasing more and more, that means it is more. X-ray chest, here the vesicles, small trophoblastic tissues can easily enter into the circulation and metastasize in the lungs, can give rise to distress, respiratory distress. That is another presentation. Embolism, molar tissue, if it is embolized in a chest, it will give rise to respiratory distress. So, one is thyrotoxicosis, unusual presentation, another is respiratory distress because of embolization of the molar tissue. And CT scan brain, that is one investigation. CT scan brain, these are not for the diagnosis, these are for assessing the spread of the disease. So, if X-ray test, if you get the deposit opacity, then you have to go for further CT scan brain to know whether it has gone up to the brain or not, embolization occurs up to the brain or not. So, X-ray chest, if metastasis, then you go for CT scan brain, if chest metastasis. Not that from the beginning you go for CT scan brain. Unusual, unless there is a metastasis in the chest, to have metastasis in the brain. So, in summary, Investigation is ultrasonography, beta ECG for monitoring, X-ray chest, especially if respiratory distress, and or for metastatic workup, and if positive, you have to go for CT brain or MRI brain. So, what will you do? If a patient comes with 8 weeks pregnancy history and having off and on bleeding and pain abdomen, and suppose there is no expulsion of the vesicle, but you on ultrasonography you find snowstorm appearance. That means your diagnosis is, and beta ECG obviously very high, diagnosis is molar pregnancy. So, treatment is suction evacuation. Suction method. Why suction? Because if there is a very much enlarged uterus, then it will not be able to reach by any forceps, ovum forceps. But if you go suction, gives negative suction, or the molar tissue will be separated from the uterine wall and will be coming through the cannula, suction cannula. That is suction evacuation. And follow-up. Follow-up means whether following evacuation all the molar tissue has been expelled, or the molar tissue is remaining, or molar tissue has embolized in the distant places, which will give rise to the high beta ECG. So that's why suction evacuation and follow-up. So you just note, suction evacuation irrespective of the size of the uterus. You know size of the uterus? 12 weeks, 20 weeks, 24 weeks, 34 weeks. Suppose 32 weeks uterus is coming, very large uterus. And molar tissue is, suppose it is 2 kg or 3 kg molar tissue. That you have to be taken out by suction evacuation. Till it is suction evacuation is the treatment. And blood for transfusion, because you see there, so many bleedings are there. So during the evacuation, a lot of blood will come along with that. So on the table, patient will collapse. So always you make arrangement for the 2 or 3 bottles of blood so that you can infuse. So during evacuation, patient gets pallor, phakashe hoye geche. You have to give blood, otherwise you will lose the patient. Blood grouping and X-ray chest must before putting the patient under anesthesia, because if there is embolization in the chest, after anesthesia you get respiratory distress. So you will be in danger. That's why before putting on the table X-ray chest mask as a pre-operative checkup, pre-operative fitness. So blood grouping and X-ray chest. So if you have to take the mask, so cervix has to be dilated adequately. So that is by laminuria tent, or it is not written here, or you have to make it dilatable. If it is already on the process of expulsion and cervix is dilated, no problem. But if it is not that, cervix is closed, then you have to make the cervix soft. That is called ripening. Means it is dilatable. If you pass dilator, it will be dilated at least 1 finger or more to dilate. You have to pass a very large bore suction cannula, about 12 or 14 size. 12, 14 size means diameter is 12 millimeter. So this is 15 millimeter, 1.5 centimeter. So like that, such a wide bore cannula. So laminuria tent, or for softening, you can give misoprostol tablet, PGE1, misoprostol tablet 400 microgram. If you vaginally give it 3 hours before, cervix will be much dilated and you can pass the dilator. Oxytocin infusion, uterus is enlarged. If uterus is not contracted, lots of blood will go. So at the same time you are taking the product out, at the same time uterus has to be contracted to expedite the process of expulsion. Otherwise, there will be tremendous blood loss. So, oxytocin infusion reduces blood loss because it makes the uterus contracted. So, the perforating vessels are passing through the reticular layer of the uterus. So, contraction means vasculature will be less. Oxytocin infusion reduces blood loss, but risk is embolization because it is contracting the uterus. So, some of the trophoblastic tissue will be pumped into the maternal circulation. So, that is the risk. Knowing the risk, you have to do it. Still, we do it with oxytocin drip, suction evacuation. That is a standard procedure. Anti-D immunoglobulin, that is a question, whether to give or not to give, because it was 10 weeks or 12 weeks size uterus. When the anti-D antigen appears in the embryo, 6 weeks. So, if it is 10 weeks, 12 weeks, you have to give, but it has no blood vessels. So, no question. But, still there is but, because if it is partial mole, it will have blood vessels, fetal elements. So, very important to know before evacuation which is partial and which is complete. Unless you know the chromosomal number, karyotyping, you will not be able to know. So, usually it is not done. So, as a whole, we give anti-D immunoglobulin to everybody. But in complete mole, it is not needed because it has no blood vessels. If the mother is Rh negative, of course. If it is Rh positive, it does not arise. Then is surveillance because it is potentially malignant. How much? In complete mole, it is 20%. So, if in your state, it is suppose 100 mole you are following up from this institution, 20 will turn into malignancy, not less. So, it is 20%. So, who are the patients is going to malignancy? So, that you have to detect by surveillance. Surveillance by serial serum beta-HCG estimation. 1 to 2 weekly. Usually 1 weekly you do not go, 2 weekly. Patients does not come so frequently. So 2 weekly is enough. So, and it should fall means fall by 10%. So if it was suppose 60,000, then by 10% means it will 6,000 it will fall. So it will be 54,000 or like that. If it is 50,000, all right, it is falling. So again 2 weeks later, if it is 40,000, okay. So in this way, this will go on normal by 6 months. Suppose lastly it is not falling so much, but even after 6 months, if you find it is not normal beta-HCG, usually beta-HCG, not beta-HCG, is less than 5. Less than 5, that is normal. So if it is more than that, that means it is not normal. That means if these things occurs, that means you are dealing with the disease of gestational trophoblastic. So long you are gestational trophoblastic disease, but when it is not falling, that means these tissues are growing inside the body, then it becomes the entity of gestational trophoblastic neoplasia. Gestational trophoblastic neoplasia. So because it is neoplasia, to some extent is a malignant situation, it will need what? Chemotherapy. In all malignant situation, we go for either radiotherapy or chemotherapy. So this is the situation we go for chemotherapy. So in that condition again, so where is the tissue? Why it is not falling? That means you have to do ultrasonography, whether it is remaining within the uterus. You have to do X-ray chest, whether it is within the chest. You have to do CT scan within the brain, or you have to do CT scan of the abdomen, whether it is in the liver or anywhere else, or in the vagina, anywhere else. So X-ray chest, in this case X-ray chest must, and ultrasonography to detect remnants of molar tissue. Not only that, if beta HCG high, what will happen? That ovary will be stimulated. So ovary will show what? Bilateral thecal uterine cyst. Ovaries are enlarged and cystic. That means HCG stimulation is there. So, and thecal uterine cyst. This is post-evacuation surveillance. This is very important because it is given in the exam as a specimen. Almost alternate. In obstetric specimens are two. One is placenta and another is this. So alternate student will be asked either placenta or H-ball. So what we are talking about, the neoplasia. So you have to give chemotherapy. What are the conditions where you have to start chemotherapy? You see, plateauing of beta HCG level means not less than 10% fall in successive estimation. 2 weekly, so 4 weeks, there is no 10% fall. That means you have to start chemotherapy. Day 1, 7, 14. So this is weekly interval. You can do it 2 weekly also, less than 10% fall. You see, these are the protocol designed by the separate institution. In your institution, you can find the separate protocol, depending on the rise will be also more than 10% on 2 occasions. That means you have to start chemotherapy. Not normal after 6 months. 6 months is passed till it is normal. Not normal. Chemotherapy you have to start. So gestational trophoblastic neoplasia, and so diagnosis is changed as I have stated. So it was gestational trophoblastic disease, but it is now gestational trophoblastic neoplasia. You see, why you are giving chemotherapy? Because we suspect that possibly the tissue which is remaining there is going on proliferation, or possibly that is malignant. So if you give chemotherapy, those tissues, trophoblastic tissues will be dead, will die. So that is the basis. But can we suggest that no question of surveillance, you just give chemotherapy to all the cases. So means to save the 20% people, you are giving chemotherapy to 100%. That is not justified, number one. Number two, chemotherapy also has so many side effects. So all the patients will suffer from side effects. So that is not justified. So chemotherapy, only those situations where these are the beta HCG is not falling. So what about the prognosis? You see, prognosis means because woman has suffered from such a potentially malignant disorder. So will the next pregnancy will turn into malignancy? Obviously question is no, because fertilization is not under control of anybody. That is natural selection. So who is going to decide that again the maternal gene will be inactivated and another sperm will come or two sperm will come? So it will not recur. But chance of recurrence is there, usually less than 4%. Less than 4%. So out of 100, 3 or 4 mother will again have molar pregnancy. So conception allowed 6 months after normalization of HCG level. So if suppose by 3 months it is normal, so 3 months plus 6 months, so how many months? 9 months. You can allow pregnancy. But till that 9 months, you have to go on surveillance of the patient. OCP may be prescribed. Why? Because to prevent another pregnancy. Because you are following up or you are going for surveillance of the woman, but if she becomes pregnant, then surveillance will be lost. So you will not be in a condition to assess the molar tissue which was there, what happens to that. So pregnancy is to be avoided. OCP may be prescribed after normalization of beta HCG level to prevent pregnancy. Risk of recurrence is 0.09, not 4%, it is quoted here, less than 1%, 0.9%. Risk of recurrence is 0.9%. Risk of choriocarcinoma, as we have said, 20%. And outcome of pregnancy, if she is pregnant, if you allow pregnancy, that will not suffer from any effect from your chemotherapy or from your previous pregnancies, that will not suffer. So pregnancy is normal, outcome of pregnancy is normal. So prognosis is good, only thing you have to allow it after 6 months of normalization of beta HCG. So who are the female more prone to develop the malignancy? Age more than 40, chance of malignancy is high. HCG level more than 1 lakh, chance of malignancy is high. Antecedent pregnancy, whether the molar pregnancy is occurring following a molar or GTN is occurring following a molar or for a normal pregnancy. Because the trophoblastic tissue, so following normal pregnancy also, this beta HCG may be high. Mature placenta was there, some trophoblast was left in the residua, they can turn into malignancy. So that is also a GTN. So GTN can happen following molar pregnancy or following normal pregnancy. So that risk of malignancy is more following molar. Interval from pregnancy more than 4 months. Suppose she has delivered a baby, within 3 months she is coming with the high HCG level, and one is delivered after 8 months she is coming. So if it occurs within 4 months, then the chance of GTN is more. Metastasis, site and number. So if there is multiple metastasis, then chance of malignancy is more. Prognosis is bad. Thecal uterine cyst more than 6 centimeter. The thecal uterine cyst if is more, 6 centimeter or more, then prognosis will be bad. So all together, you find a chart in the book, all together if the score is more than 7, then chance of prognosis will be poor. So what chemotherapy you will give? If you find that this HCG is not falling, so what is given? Methotrexate injection. Tablet can also be given, but usually we give methotrexate injection 1, 3, 5, 7 and usually 5 milligram per kg methotrexate and 1357 or injection etoposide, that is also a drug. Whenever the score is less than 7, score is more than 7 is more malignancy, outcome is poor, but score is less than 7, outcome is good, and single agent chemotherapy is sufficient. So, and multiple agent is EMACO. E means etoposide, M means methotrexate, A means actinomycin, C means cyclophosphamide, and O means oncovin, cyclophosphamide and oncovin. So, 1, 2, 3, 4, 5 drug. So, if score is more than 7, you have to give from the beginning 5 drug. Is there any place for surgery in this situation? Because only malignancy which is curable by chemotherapy is choriocarcinoma, means trophoblastic tissue carcinoma. There is no place for surgery, but in certain conditions, place of surgery is there. Hysterectomy you can do, suppose you are not taking the risk of embolization or anything. So, in mass, mole with uterus you are taking out, hysterectomy. That could be done if age is more than 40 years. Because I have already stated, age of 40, chance of malignancy and outcome is poor. So, 40. Bleeding not controlled, because from the uterus you cannot control bleeding. What will you do? If you have to give chemotherapy, chemotherapy will take time to respond, at least 48 hours. So, by the time bleeding, the patient will die. So, only thing, bleeding not controlled, you have to go for hysterectomy, removal of the uterus. That is also not very easy procedure, because tissues are so vascular, so friable, in OT table you can lose the patient. Removal of the thecal uterine cyst not required. Ovaries are enlarged, so big thecal uterine cyst, they need not go for surgery, because once the HCG is controlled, comes down, the cyst will also be reduced in size, Follow-up is necessary, because you may be complacent that you have removed whole mass with the uterus, so there is no question of follow-up, no, because embolization risk is there. So, even after surgery, you have to go for follow-up. So, what are the other conditions you have to exclude with the molar pregnancy? You know, bleeding in early months, 3 situations usually. One is abortion, possibly that class is taken. Second is ectopic, that has been taken or that will be taken. And third is molar pregnancy. So, 3 situations. So, diagnosis and everything, because you are the classes are taken, you will be able to distinguish. So, number 1 is missed abortion. Missed abortion means the fetus is dead. So, placenta is there. So, picture of snowstorm-like appearance, same picture will be there on USG. So, USG, you are in a confusion whether it is a missed abortion or it is a molar pregnancy. So, what will you do? Beta HCG. In missed abortion, beta HCG will be less, but in molar pregnancy, beta HCG will be very, very high. So, very, very important. Then is hydropic degeneration. Placenta degeneration of the trophoblast can also occur. Hydropic like vesicular change. But that is not proliferative change. In that case also beta HCG will be less. And not only that, you see in hydropic degeneration, you are having both X and XX. So what will have? P57 will be positive. But in complete mole, P57 is negative. So whenever you are a confusion, you have to go for chromosomal karyotype and immunohistochemistry. Degenerated fibroid. The degenerated fibroid is very important because the fibroid also gives rise to the picture of like molar pregnancy. Fibroid, the echogenic mass, very big fibroid, but beta HCG will be negative. But confusion is it presents with bleeding and bleeding problem. So irregular bleeding PV, you will be thinking that it is because of a fibroid, but actually it is a case of molar pregnancy. And if you don't go for estimation of beta HCG, you will not be able to diagnose. Serum beta HCG will be low and pregnancy is negative. So very important. And immunostaining is positive in all these situations, but immunostaining is negative in complete mole. And follow-up. So these are the situations where follow-up is not needed. So that's why you have to distinguish all these things. So now we have come to a situation to divide it, the benign and malignant. Benign is Hydatidiform mole and partial mole. And malignant is invasive mole, invading the myometrium and may penetrate the myometrium and giving us to shock, distension, intra-abdominal hemorrhage, bleeding. That is called invasive mole or perforating mole. And choriocarcinoma. Choriocarcinoma means villus structure is lost, histopathology, but we do not go for histopathology. Beta HCG is very high means choriocarcinoma, and you have to treat it by chemotherapy. And placental site trophoblastic tumor. So following delivery, suppose 4 weeks or 6 weeks back, that is delivery of the placenta. But after that bleeding going on. And on estimation, because after delivery beta HCG is likely to fall by 2 or 3 weeks. But if you find still it is high, that means it is placental site trophoblastic tumor. And unique is this placental site trophoblastic tumor is not from the syncytial cyto, it is from the intermediate trophoblast. It has not so much of growing power, so it will not metastasize. It will not respond to chemotherapy. More the growth, more the response to chemotherapy. But this is will not respond. So here is the place for surgery. You have to remove the uterus, otherwise the bleeding you will not be able to control in no way. So that you have to diagnose. After you remove the uterus, you send the uterus for histopathology, they will say it is not choriocarcinoma, it is placental site, intermediate trophoblast. So only histopathology can give rise to give the diagnosis, nobody else. And endothelial trophoblastic tumor, same thing. So histopathology only will be able to diagnose. Presentation is with bleeding. So following delivery bleeding means what? PPH, secondary PPH. So secondary PPH where it is not controlled, everything else is done. So you have to go for hysterectomy, send the for histopathology, you will find these are the histopathology picture. Though rare, but it has been recorded. So in summary, 20% chance of malignancy, diagnosis and monitoring by beta HCG. Chemotherapy cures the disease. Choriocarcinoma or molar pregnancy, chemotherapy enough. Pregnancy allowed after 6 months of normalization of HCG. So, invasive mole, already we have talked much, myometrium and respond to chemotherapy. So, placental site trophoblastic tumor, all those things does not respond to chemotherapy. But though you have detected that it has grossed into the myometrium, but need not do hysterectomy. You give chemotherapy, it will respond. So, and presented as gestational trophoblastic neoplasia. Placental site trophoblastic tumor presented with PPH and hysterectomy is needed, already told. Thank you.